Okay, last time we ended up on a question. What if instead of climbing a mountain and lowering pressure, we went the other way and we deliberately raised it? Here's a hard limit to start with. FiO2 can't go past 100. 100% oxygen is the ceiling for concentration. There's no such thing as 110%. But FiO2 is only concentration. Partial pressure also depends on total pressure around the patient. And total pressure doesn't have to stop where we're used to. Picture that same patient breathing 100% oxygen at normal atmospheric pressure. Now, put that patient in a chamber at about 3 times the ambient pressure. The FiO2 can stay the same, but the total pressure surrounding the patient is dramatically higher. And because that total pressure is so much higher, a lot more oxygen ends up dissolved and available, even with the concentration unchanged. So once FiO2 is already maxed at 100%, pressure becomes the only lever left for pushing oxygen pressure higher. That's the whole idea behind hyperbaric oxygen therapy. This next slide is where 3 laws you've already learned all show up in the same room doing 3 different jobs. Same chamber, same increase in pressure, 3 separate consequences. Let's take a look at them one at a time. Boyle's law states that as pressure rises, gas volume falls. Any gas bubble sitting inside the body gets physically smaller, right? And Dalton's law states that the same oxygen fraction, if total pressure rises, oxygen's own partial pressure rises with it. Same principle as the alveolar equation, just applied at a much higher total pressure. Henry's law states that the higher the oxygen partial pressure climbs, the more oxygen physically dissolved into plasma, that liquid part of the blood, separate from what's carried on the hemoglobin. So 3 laws, one chamber, one increase in pressure, and each one changes something different about what's actually happening inside the patient. Keep all 3 in mind because we're going to look at that a little bit closer. So let's go back to slow down on Boyle's law specifically. Picture a small gas bubble sitting inside a blood vessel, blocking it. Now, picture increasing the pressure all around that bubble. It doesn't vanish instantly, it gets smaller physically. And smaller volume, smaller diameter, less of an obstruction, right? That's exactly what is happening in 2 conditions you'll hear about with hyperbaric therapy. Decompression sickness, where nitrogen bubbles form in tissues after pressure drops too fast, like in diving, and arterial gas embolism, where air actually enters the circulation. In both cases, this isn't just physics anymore. We're using the same pressure volume relationship to physically shrink something that's blocking blood flow inside a real patient. Now, let's talk about where that extra dissolved oxygen actually goes. Think of hemoglobin as your normal fleet of oxygen delivery truck. Under normal conditions, those trucks are already almost completely full. Hemoglobin is close to fully saturated, just breathing regular air. So adding more oxygen concentration doesn't give you many more trucks to fill. But hyperbaric pressure opens a different option entirely. Instead of relying only on the trucks, oxygen starts dissolving directly into the plasma, the fluid the trucks are driving through. That's Henry's law again. Higher oxygen pressure, more oxygen dissolved in the liquid itself. At high enough pressure, that dissolved oxygen alone can meaningfully support tissue, even in patients whose hemoglobin can't carry oxygen well. That dissolved oxygen is one benefit. And in the carbon monoxide poisoning, the very high oxygen pressure also helps drive carbon monoxide off of the hemoglobin a lot faster. Okay, so who actually gets hyperbaric oxygen? There's a list of approved uses, but instead of memorizing it as a random set of names, group these by why the therapy actually helps. So, like bubble problems, air or gas embolisms, and decompression sickness, pressure physically shrinks that bubble, right? And then in toxic exposure, carbon monoxide poisoning, right? Think carbon monoxide. High oxygen pressure speeds up how fast carbon monoxide gets knocked off of the hemoglobin. And then with the anaerobic infection, Clostridial myonecrosis, sometimes they call it gas gangrene. High oxygen levels are directly toxic to bacteria that only survive in low oxygen environments. And then there's threatened tissue where certain problem wounds and compromised skin grafts where extra oxygen supports healing and new blood vessel growth. So you have bubbles, the toxins, anaerobic bacteria, and struggling tissue for completely different reasons, but the same underlying tool is used. If you understand why each one belongs on the list, you don't have to memorize the list at all. Now, here's the flip side, and it does matter just as much. Everything we just covered happens while pressure is going up. But at the end of treatment, pressure has to come back down. And Boyle's law runs in reverse. As pressure falls, trapped gas expands, right? That's usually fine, but think about a patient with an untreated pneumothorax where air already trapped around the lung. During decompression, as pressure around the patient drops, the trapped air expands, and expanding air in an already tight space can push towards that tension pneumothorax. And that's a genuine emergency. That's why the untreated pneumothorax is considered an absolute contraindication to hyperbaric therapy. Everything else we might worry about is a relative concern, weighed case by case. A few of those other safety concerns worth knowing, just briefly, barotrauma to the ears and sinuses from the pressure changes themselves, and then oxygen toxicity from prolonged high oxygen exposure, and fire risk since an oxygen rich environment requires strict control of ignition sources. Question before we move on: why would a gas bubble inside a blood vessel and a pocket of gas inside the pleural space respond in opposite ways during hyperbaric treatment? So remember that compression shrinks the bubble while pressure is high, but trapped pleural gas is a danger on the way back up when pressure falls and that gas expands. So here's where we land at. Hyperbaric oxygen doesn't work because we're somehow giving more than 100% oxygen. It works because pressure changes what oxygen and trapped gas can actually do inside the body. But pressure isn't the only physical property we can manipulate. Sometimes the real problem is just getting gas through a narrow airway in the first place. And that's where changing the gas itself comes in.